Thank you everyone for joining us. We're going to get started on our meeting today. So I'm going to go ahead and introduce Dr. Saguil as he pulls up his slides. So you all know Dr. Saguil, but I will introduce him briefly. So Dr. Saguil is a professor of family medicine in our department at USU. He's also an associate dean for regional education in San Antonio. He was former associate dean of admissions, and he is a current president of USAFP and the vice chair of AAMC's MCAT Validity Committee, and also a contributing editor to the AFP. He earned his BA in chemistry from Duke University, MD from University of Florida, and MPH from University of Washington. He had deployed to Afghanistan, served as Chief of Primary Care for the NATO Role 3 Multinational Medical Unit in Kandahar, Afghanistan. So with that, I'll hand it over to Dr. Saguil for his presentation. So as we go forward, if you have any questions, you can speak up and ask Dr. Saguil the question, or you put it in the chat and I can ask the question. If you prefer to wait until the end, you can, but we'll encourage you to ask as we go along. That way, if you run out of time, your questions will be answered. And then at the end, I'll request that you complete evaluation. I'll put the link in the chat. So please complete that evaluation at the end. And that is it. We'll get started with Dr. Saguil's presentation.
Perfect. Thank you, Dr. Gosa. And thank you, everybody, for being willing to slide this 1 hour to the right. I have my mandatory transition classes right now. And as an added bonus, they're also installing a new yard in the front as well. So any machinery that you hear going on is likely coming from that edge of my house. So I apologize. If I need to speak up louder, just please let me know. But I'm really excited that we have an opportunity to talk about multiple sclerosis. It's been a minute since I've given a presentation on this topic. The last time I did it was with Ed Farnell, and I think that was back in 2012, maybe, at the AAFP's former scientific assemblies. So really excited about all the things that have happened since then that we can share together today. And this is the agenda. So we're going to talk about the diagnosis, the evaluation, and the treatment of multiple sclerosis. We're going to use some patient cases to make it far more interactive and hopefully far more interesting as well. And then we'll also touch on topics such as epidemiology and differential diagnosis. And we'll also have that pathophysiology slide that'll take you right on back to your days in medical school as well. So be excited about that. When you raised your hand, is there someone that has a question?
No, your screen is not on presentation mode.
Oh, no. So what are you seeing right now? Uh-oh.
I see the slides in the, I don't know how to describe. It's not in the presentation mode.
Okay,
right.
Well, let me see if I can try that again and see if this will work. Okay, how about now?
Let's see, hasn't come up yet.
Okay, no worries. We have multiple different ways of skinning this cat, so let's see. Okay, if I do it like this, you're seeing it, correct?
Yes, but I see the slides and I see your notes, and then I see all the tabs on the left also. Okay. So if you go to the.
How about this? Is that working now?
No, it's not. It's just staying on. You know how when you work on your.
All right. So let's do this.
I know.
How's that? That's probably as good as I'm going to be able to get with my limited technical abilities.
That looks better.
Okay. And then what I can do is I can even hide these ribbons. Okay.
Yep, that looks good.
So we'll go with this. No, my pleasure. Yeah, absolutely. So as long as I can advance the slides, we should be okay. So this is what we're going to talk about. And so we'll go on from there. And advancing the slides may be problematic. Okay. All right, I'm clearly not up to the challenge of doing this. Let's try it here. Aha, here we go. Okay, perfect. Are you seeing an epidemiology slide? All right, all the technical issues have been worked out. There'll be no more gremlins for the rest of this presentation. So epidemiology, every medical lecture that I've seen has some kind of numbers in it. And so these are the numbers I wanted to share with you. there are roughly anywhere between 2 to 2.3 million people living with multiple sclerosis worldwide. And so if you want a comparator, that's basically the entire population of Slovenia on the low end, all the way up to the population of Botswana on the upper end of it. In the United States, we have 400,000 people living with MS. And so for a comparison there, we've had over 615,000 now deaths as a result of COVID. So all of us have been impacted, all of us have been touched by someone who's passed away with COVID. Well, 2/3 of that number are the same as the number of people that are living with MS. So we've all taken care of patients with MS, or because we do move around quite a bit, we've taken care of patients that will eventually develop MS or who developed MS after we were done participating in their care. So it's a good thing for us to know about. And then the prevalence in the population at any point in time is about 50 to 300 out of 100,000 people. So you would have to basically survey 333 people to find one with MS, or up to possibly 2,000. It's a very, very common disease. Risk factors from MS, as you remember from medical school, the further away you live from the equator, the higher your risk of developing multiple sclerosis. So temperate zones of America, Canada, Australia, if you're in the southern hemisphere. Obesity, a risk factor. Smoking, a risk factor, two things that tend to increase the inflammatory state in an individual's body. Interesting enough, mononucleosis, also an association with multiple sclerosis. I don't remember that from the previous time that I gave this presentation. And then about 3/4 of the people that develop MS are female. And then if you have a first-degree family member with MS, your lifetime risk of developing multiple sclerosis yourself is anywhere between 2 to 4%. So that makes it far more common in people that have a relative with multiple sclerosis. This is the part of the pathophysiology I'm excited to share with you today. So just as a reminder, multiple sclerosis is an autoimmune disease. It's a lymphocyte-driven inflammation that causes the pathophysiology. And so if you look at the top left, you see this normal neuron just going about its business, having a great day. And here comes these lymphocytes to basically initiate an inflammatory cascade. And then if you go directly below that, so center left, you see that they're stripping the myelin is being stripped away, which is going to have impacts on how the neuron conducts its signal. And actually, though, that lymphocytic inflammatory response can go on to lead to transection of the axons, basically robbing them of their ability to propagate signals. Well, as this is going on, you're also getting activation of microglial cells, which can either potentially proliferate the inflammatory response. So if you look at the top right of this first picture on the left, where it says degeneration of chronically demyelinated axons, you see there a microglial cell actually involved in transecting that axon, or those microglial cells can actually lead to the remyelination of the axon, which is why MS, the most common kind that we often see, is where you have relapsing and remitting, because people get a neurologic deficit and eventually you get remyelination and improvement of that neurologic symptom. And so in the bottom center, you see the microglial cells remyelinate, are basically assisting in helping to create the milieu in which that axon can be remyelinated. And then if you go over to the image on the right side of the screen, you see the oligodendrocyte, which is responsible for producing the myelin sheath around these axons. They're called Schwann cells in the peripheral nervous system. You might be familiar with that term. Well, it's the oligodendrocytes in the central nervous system. And then you can see the macrophages, the T cells. If you go to image number 2, you can see antibodies and complement fixation, such that you see demyelination of those axons and potentially even apoptosis of that oligodendrocyte. So this is what happens to cause those relapses in multiple sclerosis, just as by way of a refresher for you. And then if I go down to the next slide, we'll start going into our cases. So we've looked at the microscopic level. Let's go a little bit macroscopic. Let's talk about our patients again. So I recognize that all of you are too young to have seen this person in her prime. For some of you who studied 50s pop culture, then maybe you'll recognize who this is, and I'll tell you just a little bit later. But this person was a child star who was in a whole bunch of different, she was in a very particular television show that was very popular at the time. She also did a whole bunch of beach type movies. And so did those as a child. Later on at age 45, they did a reunion where they went back to one of those same beaches and filmed a movie there as well. While she was filming this revival, she started noticing that she had extremity weakness in her lower extremities and was having difficulty with balance. She was afraid, actually, that other people would think that she was drunk, despite the fact that she was about as squeaky clean as celebrities come, both in that era and in the current one as well. She receded from the public eye for a little bit, and then 4 years later, there was a television interview that was done in her home. And what was really shocking was that during the interview, it was very, very clear that she was having difficulty speaking and actually moving unassisted as well. And so the question I have for you is this MS. Does she, in your mind, fit your case definition for multiple sclerosis? Does she fit your case definition for something different? And how could you tell if this was multiple sclerosis or not? So I want to stop for about 15 seconds to let you think through that. And then what we'll do is we'll actually look at the diagnostic criteria. So I'm going to stop talking for 15 seconds and stare at the camera. Okay, so moving on. These are the diagnostic criteria for multiple sclerosis. They're the McDonald criteria, and they were revised as recently as 2017. And I suspect that most of you, when you think about multiple sclerosis, you think about neurologic attacks that are disseminated, that's a big word, in space and time. And so the way to diagnose MS, the easiest way, is to come across a patient who's had 2 or more clinical attacks and has objective evidence of 2 or more lesions. If you meet those criteria, you don't need anything else to diagnose MS, assuming that MS is the most likely diagnosis. So for instance, if you have a patient who's had 2 strokes and they have all the risk factors and they look for all the world as though they had 2 strokes, that's not MS. But if the most likely explanation is MS in the setting of 2 attacks, 2 objective lesions, 2 points in time, you don't need anything else. Now you're going to still obtain an MRI on these patients and do your other workup as well, because you need to know something about the disease burden with which this person presents, because that's going to guide your therapy, but really you've already made the diagnosis. If you have a patient that presents to you and they have evidence of 2 clinical attacks, and it sounds like they're MS attacks, and they have objective evidence of 1 lesion, then you've met the criteria for dissemination in time, but you haven't quite met the bar for dissemination in space. And so what you can do in that instance is you can check an MRI. If the MRI shows a lesion in a place different from what you would have expected to cause the symptoms that you were able to clinically document, now you have evidence of geographically separate lesions, and that meets the dissemination in space criteria. You can diagnose them with multiple sclerosis. Likewise, if they've had 1 attack, but you have evidence of 2 different lesions, dissemination in space, then if you go and perform an MRI and it shows a new lesion, so now we're starting to show that something has evolved in time, you can use that to make the diagnosis of MS. And then they had left these out of the previous revision of the McDonald criteria, but oligoclonal bands are back. And if you can show oligoclonal bands on a lumbar puncture, that meets the criteria for dissemination in time, and you can use that to diagnose MS. And of course, for anybody that's had 1 attack, if they have a 2nd attack, that raises them up to the level where they can be diagnosed. If someone only has 1 attack with clinical evidence of 1 lesion, that's what we call the clinically isolated syndrome. They've essentially had what may be their 1st attack of MS. At that point, we're simply waiting for the 2nd attack or MRI evidence of multiple lesions, or maybe they have those oligoclonal bands. And then there is a type of MS. This only is about maybe 10, possibly 15% of the people who present who have the initiation of neurologic deficits, and they progress to greater and greater disability. This is what our last patient had. And for those of you who were scratching your heads trying to figure out who she was, that was Annette Funicello. She was one of the original Mouseketeers for Uncle Walt. was popular throughout the 60s with her beach movies, and then unfortunately had to leave the public eye just because she had such incredible disability as a result of MS. So those are the diagnostic criteria. I recognize now that as I look at the screen, I've been talking straight for 15 minutes, and even though my voice is really melodic and people love listening to it, we should turn it over to you for a little bit. So let's go into some cases. Oh, before we do that, let's listen to me a little bit more. These are the MRI findings I wanted to show you as well before we get to the cases. So if you look at the extreme left side of your screen, you're looking at T2 weighted MRI images. That means that the cerebrospinal fluid is white, so that one on the far left. And what you're seeing there is a collection of these ovoid lesions that are greater than ½ centimeter in size, and they're kind of clustering around the ventricle. That's very suggestive of multiple sclerosis. In the next two images from the left, so the second from the left and the third from the left, you're looking at fluid attenuated inversion recovery images, also known as FLAIR. And what those do is those make the CSF dark, so it's easier to see the lesions associated with MS or a whole host of other things. And that second from the left picture, you're seeing these periventricular perpendicular lesions. Those are called Dawson's fingers, and those are highly specific for multiple sclerosis. In the next image from the left, so the last of that single row, you see multiple lesions that are adjacent to the ventricles, ovoid, over ½ centimeter, and that's also fairly suggestive of MS. If you look at the right set of pictures, so there's two rows right there, the top images are T2 weighted images where the CSF is white. And you can see that with the CSF white, it's kind of hard to make out the lesions, but you can still see them. I don't know that my cursor is going to be showing, but if you look at when is it showing? I can see you. Okay, great. So here's a lesion right here. Here's a lesion here. Here's a lesion here. Well, down below, these are the FLAIR images, and boy, look at how much those enhance and how easy it is to make those out with MS. So those are some of the MRI findings that you might see if you're browsing through the brain yourself. Now it's time for the cases. So we'll need just a little bit of participation, so please feel free to unmic. The first case I want to give you is the professional. He's a 36-year-old parent of 2. He presents with pain in his left eye. Whenever he moves it, it hurts. You think, okay, well, I have somebody with an eye problem. I know that visual acuity is the vital sign of the eye. So his right eye is fine. It's 20/40. He could probably use some corrective lenses. But his left eye is only 2100, which is definitely new for him. And because you heard this lecture and you thought, color saturation, how can I check that? You ask him to look at one of the colorful posters on your wall, and he's having a hard time differentiating between the colors. So 3 questions to consider. Could this be multiple sclerosis? Is this something else? If it's not multiple sclerosis, but it could be, what else would you need to make the diagnosis of multiple sclerosis? So let's wait 15 seconds and then feel free to unmute and jump in on any of those 3 questions. All right, that's 15 seconds, so feel free to jump in. Everybody's had a chance to think about it now.
Oh, I assume you're getting an optic neuritis.
Okay, so we're hearing the word optic neuritis. I would say that definitely fits this case. Good. Any other comments or thoughts from you or anybody else?
MS and differentials always NMO.
Oh, I apologize. I'm not picking up very well. I'm turning up my volume.
I was just saying NMO, neuromyelitis optica.
Yeah. Yeah, neuromyelitis optica used to be known as Devich syndrome. Should be on our differential. We can talk about that, definitely. Good. Any other thoughts? If you volunteer thoughts now, I won't force you to go through and tell me what you would prescribe in different situations later.
I'll go then. take me off the list later. No, I mean, I think, going back to the other questions, right? I think this could be MS for sure. Definitely, if this is a sort of an acute thing, then we either need waxing and waning or recurrence of symptoms according to your, the McDonald scale that you showed before, and or now, again, some confirmatory laboratory tests or imaging.
Perfect. I think that's a great place to take this a little bit forward. So could this be MS? The answer is absolutely. And this is a case presentation of optic neuritis, which could be what the first manifestation of someone who's going to develop MS. Right now, by McDonald's criteria, we have a clinically isolated syndrome. We have one attack with lesions in one area at one point of time. For them to go on and declare themselves as full-on MS, we'd have to do one of several things. Either number one, we could wait for them to have another attack. That seems kind of cruel. We could get an MRI and see that they have lesions other than in the optic nerve. So in addition to the demyelination that's happening with the inflammation in the optic nerve, we see that there's lesions somewhere else. So that's dissemination in space. And then also we could potentially offer this patient a lumbar puncture for diagnostic purposes. And if they had those oligoclonal bands, then we would meet dissemination in space and dissemination in time. So this definitely could be MS, but it absolutely could also be neuromyelitis optica as well, because optic neuritis is one of the things that can happen in that condition, in addition to other things involving the facial nerve and possibly the spinal cord as well. So right now we have a strong suspicion this is MS, but it could be some other things. We have some more to do. Good job with that case, everybody. Well played. Let's go on to the next one. This is the construction worker. So here I have a 42-year-old who is newly married. She presents with subacute back pain, and she's really not worried about that all that much because honestly, the job that she does, she has back pain pretty frequently. But she was worried because she has bilateral lower extremity paresis as well as pain, and that's not normal for her. You do a thorough history, you do a thorough examination as well. On exam, she has 3 out of 5 strengths, so she's good against gravity, not so good against anything else. And honestly, you notice that she had to be escorted into the room by her significant other. And so pretty profound lower extremity weakness. On further questioning, she reports that she had a mini stroke 2 years prior. She was hospitalized. She had a CT scan that showed there was no evidence of blood, but she was lost to follow-up because she was supposed to have an MRI and some other additional studies because she didn't have insurance at that time. But she's now married to a military member. And so 3 questions here. Again, we'll give you 15 seconds to think it through. Are the lower extremities symptoms that could be indicative of multiple sclerosis? 2, what do you think about this mini stroke history? 3, kind of put it all together. What do you think is going on? And then 4, if you do think that multiple sclerosis is on the differential, what else would you need to make the diagnosis? So again, 15 seconds, and I'll prompt you to start answering. Okay, so feel free to jump in. Again, anybody that answers now won't be called upon to help me tailor disease-modifying therapy later. Okay, let me back it down just a little bit then. This particular presentation with pain and weakness bilaterally and possibly some paresthesias in the lower extremities, does that tickle any neurons for any particular disease entities? We actually had a case of this at Fort Hood not too long ago. I think it was back in February.
When I worked for a veterinarian, this would be tick paralysis.
Okay, that's pretty cool, actually. I don't know if it's the same pathophysiology, but so. I don't know my vet medicine. So this is a case presentation. Go ahead.
Transverse myelitis.
Yeah, and thanks for offering that. This is a case presentation of transverse myelitis. And so transverse myelitis, you have basically broad inflammation at one or several spinal levels. Depending on how high up it goes, you can get neurologic deficits, including the upper extremities. You could potentially run into a case where you have difficulty breathing if it goes up into the levels that produce the phrenic nerve. And so this person's fairly fortunate that's a little bit lower down. Can be progressive, and of course it needs to be treated pretty quickly. You have to recognize the diagnosis. We had a gentleman that was hospitalized, and the best we could figure, the only new thing besides whatever you can potentially pick up from the environment is that he had had the COVID vaccine not too far back. And so our thought was that this could potentially be transverse myelitis associated with the inflammatory response generated by the COVID vaccine. Could this be an initial manifestation of multiple sclerosis? Yeah, so rhetorical question. The answer is yes. So both the optic neuritis and the transverse myelitis could potentially be the first manifestation of somebody having multiple sclerosis. So knowing that this could potentially be multiple sclerosis, now what are your thoughts about this mini stroke, this clinical episode that she has documented with a hospital stay? Does that make you more or less suspicious that as you put this all together, you may be looking at someone who has previously undiagnosed multiple sclerosis? And I can't see faces or anything like that, so I need a little unmiking to let me know what you're thinking.
Yeah, I mean, you're certainly matching the neurologic deficit separated in space and time. So you're hitting that mark, but lots of things cause facial droop that aren't MS. So I think it's on the differential.
Yeah, absolutely. And I think this is a case where if you had the MRI and it showed the findings associated with transverse myelitis at that particular spinal level. So here you're going to be getting an MRI of the lumbar spine. And then also at the same time, because you're worried about MS, you're going to get an MRI of the head. If you see the lesion suggestive of multiple sclerosis, you're going to make your diagnosis based on that. So this is someone that very well may already have all the criteria needed to make the diagnosis. So good. Thanks for going through those cases. All the rest of you, I'm going to call on you for the drug treatment regimens. So this is a great place to hop off. Just joking. We'll be fine. It'll be benign. So also wanted to point out to you that there are other conditions besides multiple sclerosis associated with demyelination, and that could also present in such a way that you might think, oh my gosh, this sounds just like multiple sclerosis. And I won't go through all of these here, but we did talk about neuromyelitis optica. The first time that anybody shows up with an acute neurologic deficit, you have to think stroke. So think about your ischemic vasculopathies. There are some connective tissue diseases that can cause symptoms that look for all over the world like multiple sclerosis. And here you're relying on your clinical, kind of like your differential diagnosis, lab studies to help make those differentiations. Findings look a little bit different on MRI as well. And there's a couple of other ones here for you also. And I will make these slides available for you just in case you want to look over some of them. And I'll make sure that they have all the references too in case you want to know a little bit more. So with that, let's talk a little bit about treatment. So for a moment, I want you to recall the year that you graduated from residency. Because as you know, and I recognize that there are a couple students on here, so that hasn't happened yet, and that's fine. But as you know, the further you practice out from residency, the less smart you are compared to that one day, that one glorious day in May or June, when you were the smartest you're ever going to be as a family physician. And so keeping that day in your mind, I'm going to advance to the next slide and show you all the panoply of different medications that are available for MS. I graduated from residency in 2002. At that time, we had the interferons available for the treatment of MS, and they'd only been on the market since 1993. We had glatiramer, Also a fairly benign medication that did help slow the rate of relapses. And then for people that burst through those, still had a lot of activity, we had natalizumab and we had mitoxantrone, both of which have significant comorbidities. Natalizumab is associated with cardiomyopathy, and mitoxantrone is associated with progressive multifocal leukoencephalopathy. But since that time, we've had a whole bunch of other medications, including in 2010, the introduction of fingolimod, Gilead is its trade name, which is the very first medication that could be taken orally for the treatment of multiple sclerosis. So here's a list of your agents. These include all the ones you saw on the previous slide, as well as additional ones that have been FDA approved since 2017, including we had one that was approved just earlier this year. It's in this list somewhere. I don't recall exactly which one it is. So you don't have to memorize that because I'm going to show you another slide with another table. So here is a list of those same medications in the order of their introduction. You see the generic names on the side, their trade names in the middle, the year they were introduced, their indication, and you'll notice that most of these medications are indicated by the FDA for relapsing, remitting multiple sclerosis. That doesn't mean we don't sometimes use them for people with primary progressive multiple sclerosis, especially if they're having exacerbations. But the true indication is for those that are relapsing and remitting. And then on the side, you can see the dose and the route. So up until 2010, you were getting your medication either subcutaneously or by IM injection or intravenously in a number of different frequencies. Ocrelizumab at the very bottom of the page is fairly interesting because it was the first medication FDA approved for the treatment of primary progressive MS, and it works on the B cells by causing lysis of those cells that have the CD20 moiety on them. And here's the rest of the medications, including the ones that have been introduced more recently. Okay, so that should have been adequate time to memorize all of them. What I wanted to do was to take you on a survey of the different mechanisms of action associated with these medications, just so you can have an idea in your head of kind of the way that they work to decrease inflammation and to prevent T and B cells from getting to the brain and cause the damage in the first place. So that first medication was interferon. Interferon works by down-regulating the major histocompatibility complex so that it can't show off as much antigen, and by doing that, it helps to down-regulate the immune response. And we also think that interferon helps prevent T and B cells from crossing the blood-brain barrier. The other early medication that we had was glatiramer. Works by several different mechanisms. It also works at the level of the major histocompatibility complex, but also takes those T cells and as they differentiate, tries to preferentially shunt that differentiation towards the types of T cells that actually downregulate inflammation. And then after those two medications, early on, what we had to go to next was either mitoxantrone or natalizumab. Mitoxantrone helps to prevent the proliferation of B and T cell lymphocytes. Natalizumab helps to prevent these lymphocytes from going across the blood-brain border. Again, in 2010, we had our first oral medication, fingolimod. That helps to sequester B and T cells in the periphery, like in lift tissues, so they don't get an opportunity to go across the blood-brain barrier. And then one of the newest medications is ocrelizumab, and that one helps to cause a destruction of the B cells with that particular moiety on them, and that helps with the immune response. So lots of information on here. We won't go through all of them. Just want to give you a sense of how they're working both in the periphery as well as in the central nervous system and across the blood-brain barrier to help prevent the inflammatory response that causes the demyelination that we saw in that early slide previously. Things that you might need to know. So I don't think any of us feel comfortable probably starting any of these medications. I think if I was forced, as I was practicing in a more rural area, I didn't have easy access to a neurologist, or my patient didn't have the ability to pay for that type of consultation, I think I'd feel okay personally with starting somebody either on interferon or on glatiramer, because they have fairly benign side effects. With the interferons, patients would say they felt like they had a flu. With the infusions, and rarely there's liver toxicity associated with them. But again, that's very rare. You monitor them with CNPs and CBCs. With glatiramer, it's mostly injection site reactions that patients have, and there's no routine monitoring that goes along with them. But you start getting into the other medications, which quite a few of them tend to be just a little bit more efficacious than interferons and glatiramer. And then you start running into things that you'll need to surveil. So maybe you don't start patients on these medications, but maybe they've seen the neurologist, they come to you and it's on their med rec. And so just knowing a couple of key buzzwords will help you care for those patients and also help you with your board certification examinations. So probably one of the biggest ones here is natalizumab. It has a very high incidence of progressive multifocal leukoencephalopathy caused by the John Cunningham virus. And so about up to 1 in every 500 people, am I doing the math correctly? I think so. No, 1 in every 50? Oh, wow. Sorry, can't do the math that quickly, but quite a few people have developed PML as a result of being on natalizumab. So for someone to start on that particular medication, you need to check them for the JC antibody, because if they have a certain titer of that antibody, they just won't start them on that medication and they'll use something else. You'll see that some other medications, like the other sphingosine 1 phosphate blockers and also cladribine, also have a risk of PML, but it's not nearly as high as what you see with natalizumab. A couple other things here to know: mitoxantrone, one of the earlier ones that we used when patients had more aggressive disease, that one's associated with cardiotoxicity. So that's one of those questions that you might see in a patient that has a predisposition, which would you not consider using? So there you have that one right there. And then of those oral agents, the fumarates are associated also with PML, lymphopenia, so immune suppression, more likely to have diseases, infectious diseases. And then again, the sphingosine blockers like fingolimod and some of the others are associated with heart block and arrhythmias. So you have to watch to whom you would prescribe those, or if you have a patient that comes to you on them, just recognize that when you're adding on other medications for their other comorbidities as well. Pregnancy. So the good news about pregnancy and MS is that because it's a relatively immunosuppressed state, most people are going to feel better and have less relapses during pregnancy. And the even better news is that your pregnancy outcomes, if you have MS, are fairly similar to those that do not. If you're disabled by your MS, then there's a higher risk of C-section. Women with MS, their babies tend to be just a little bit smaller by a few hundred grams. But otherwise, for everybody else, the C-section rate, the neonatal outcomes are completely the same. So that's good news. There is a tendency to have a higher rate of relapses in the postpartum. Now, the recommendations from the folks that make the guidelines is that before someone gets pregnant, if at all possible, you'd like to optimize their disease management. So you want for them to be stable before they get pregnant. Generally speaking, you stop the disease modifying therapies before they conceive. Fumarate, for instance, has known teratogenicity, and we just don't have great studies on the other ones. If you had to keep somebody on a medication because they couldn't get quite stable, or maybe you looked at the MRI burden, you were really concerned about the lesions that were there, you could potentially put them on interferon or keep them on glatiramer. You would try to avoid other medications in that instance. Oops, I think I went too far. I double-clicked here. Bottom line, all of the medications are effective at reducing relapses. And the guidelines say, really, you can potentially start with almost any agent that you want. If you look at the American Academy of Neurology's guidelines, they didn't make a strong recommendation for starting with one versus another. The choice of initial treatment is highly dependent on two things: the disease activity on the one hand and the patient preferences on the other. If a patient has more active disease or worse looking MRI, you tend to lean towards some of these high efficacy treatments. So instead of interferon and glatiramer, you maybe start them off with something else. If they have less active disease, then maybe you use those medications that they're effective. They're not as effective potentially as some of the other ones, but they have less risk of side effects. And then you talk to your patient. Are they okay with a sub-Q medication, an IV medication, an IM medication? Will they remember to take a PO medication every day? How bad is it in the patient's mind if they have a relapse? Because some patients may be very intolerant of the idea that they may have a relapse, and even though they have fairly well-controlled disease, they want to be on something more aggressive. You think about the adverse effects and your patient's comorbidities as well, and the need for your routine monitoring also. So all these factors go into play in helping a patient decide what medication they wish to be on. Good news is that there are some guidelines that kind of give us an idea of what medications a person should be on and when, even though the American Academy of Neurology hasn't provided that type of information for us. In the UK, with their national health system, they've given us a fairly nice flow chart. So I want to show you just a couple of those. Again, not to make you people that feel comfortable necessarily prescribing these medications, but to give you a sense when your patient reports their medical history, yeah, I was on this, but then I switched over to this, and now I'm back on this. Here's maybe some of the reasons why that happens. So this is for somebody who has had a single clinical episode. If they've just had that one episode and their MRI is clean, the UK folks recommend no treatment for that individual, although I must admit that's an area of controversy. There are quite a few here in the US that would actually treat them. If they have an episode and they actually meet those McDonald's criteria, you could continue to not treat them, or if their MRI doesn't look too bad, interferon, glutathione, if their MRI is looking bad, like they have aggressive disease activity on MRI, then this is a patient that maybe you would step up to a more effective therapy like alemtuzumab or ocrelizumab. It's really fun saying all these monoclonal antibody names, but recognize that if you put them on them, alemtuzumab is associated with blood clots and thyroid disorders. And then with ocrelizumab, you run an increased risk of malignancy. So there is a trade-off that happens there with these medications. And that's probably why most of us would not feel comfortable starting somebody on something like that. If you have someone that fully meets the McDonald criteria, again, you think about whether or not the disease burden is such that they can tolerate maybe a lower activity, lower side effect profile medication like the interferons or glutathione, or if they need to be on something just a little bit more aggressive. And then also if the patient's preference is to be on an oral as opposed to an injectable medication, this is where you see something like fumarate being used. But remember, there's a small risk of PML with that medication. And then if you have someone that has rapidly evolving severe symptoms, that's again like with the previous case where you would go directly to one of those monoclonal antibodies that, although they have higher side effects, more efficacious for getting people into remission. If people are not tolerant to the medication you give them for whatever reason, like the interferons are making them feel like they have the flu every single time they take it, you can switch among medications in the different classes. That's what this is simply showing here on this slide. And then if someone is on a first-line therapy, but they're having activity on that therapy, so they're having clinical episodes, relapses, and that's when you start thinking about a second-line drug. So if they're on one of those lower efficacy drugs, again, the interferons, glutathione, maybe they were on the oral drug fumarate, that's when you move them over to maybe those monoclonal antibodies like alemtuzumab or ocrelizumab or cladribine, which is a PO medication, but also carries the risk of PML. And then if they have rapidly evolving disease, that's where we see natalizumab come back, even though there is the potential risk for PML. That was the one that was like 19 out of 1,000, okay? And then for those that still have disease activity on their second line treatment, that's when we start thinking about the idea of whether or not someone might benefit from an autologous stem cell transplant, which I think has been shown to bring people into remission like up to 70% of the time. So lots of stuff with the medications. Let's go through a case. I want to show you this isn't nearly as scary as you maybe think it is, although granted, these are not the medications that we're going to feel comfortable prescribing in most cases. So Sylvie is a G1P1, 34 years old. She's not currently pregnant. She has clinically isolated syndrome. Maybe she had an optic neuritis or something else. And her MRI only shows the one lesion consistent with CIS. So based on that, feel free to unmic. These are pretty, I try to keep these pretty in line with what we had already talked about. How would you treat her? Question is, would you treat her, and with what would you maybe consider?
I think based on the UK guidelines, you would not treat her, but you could consider treating with maybe interferon.
That's exactly right. This is someone that you could maybe consider not treating. And there's even US neurologists that would say, hey, let's just wait and see how things go. Because remember, optic neuritis, if that's what she had, is also the presenting syndrome, or could be one of the presenting symptoms of neuromyelitis optica, which has a different treatment algorithm. But if you were to start on something, interferon or glutathione would be very appropriate for her. Now, move on to the next question, and this is where I'll start answering them for you, so you don't have to feel like you're going to be on the spot every single time. 6 months later, she has a second attack, different location, confirmed by the MRI. If she wasn't on a medication before, this would be an indication to start her on medication, because these medications have been shown to prevent the accumulation of disability over time. And so you want to keep them functionally viable as long as humanly possible. So start her on a treatment if she already was on one. If she wasn't on one. If she was already on one, you might consider moving her over to one of those monoclonal antibodies after you had that shared discussion or shared patient decision-making discussion. She does well for 1 year. Her MRI does not show new lesions. She wishes to become pregnant. This is maybe where, now that she's stable, you would take her off of medications so she can go through without risk to the fetus, because we think that during pregnancy, her disease should also be quiescent. Pregnancy goes well, but she has symptoms in the postpartum. This is when you'd restart the medications. You treat her acutely, because these medications take anywhere from 2 to 3 months to be active in preventing those relapses. And we'll continue the case. So now she's G2, P2, you delivered her. It was a great experience for everybody. And she's 37 years old. She's had increasing symptoms on her medication, and her MRI shows increased disease activity. If you hold on 1 second, my son decided this was the exact moment he wanted to start playing his piano. So let me ask him to stop for just a moment, and I'll be right back. Although in retrospect, it may have been cool for you guys to hear my son in the background. And if you want information on where to listen to his stuff online, I can give it to you afterwards in a different link. Okay, so increasing symptoms on her medication, and her MRI shows increased disease activity. So if she was on interferon or if she was on glatiramer, maybe this is where you'd switch her over to one of those monoclonal antibodies. If she was already on the monoclonal antibody, you could switch among different ones. So ocrelizumab to I forget what the rest of the name is, to MAB. Or you can consider cladribine, which is a PO medication that's also for the people that have more aggressive disease. The new medication works well for a few years. She's had 2 additional relapses in the last year. This is where, again, you can switch between classes, or this might be the point where you would consider that she should be referred for consideration for a hematologic stem cell transplant. And then the final question is, decades later, Sylvie has had progressive loss of function and asks which med she takes now, and that really is dependent. The British guidelines say that once you get to a certain level of disability, i.e. you're no longer ambulatory, that the medications really have no role, and you might even consider stopping the medications at that point, and that would be consistent with the thoughts of many in the US community as well. So that's about the chronic treatment. Let's talk about something we probably all feel a little bit more comfortable with, and that's acute exacerbations. The answer is steroids, and that's really all you need to know. Oral steroids, IV steroids, have been shown to have comparable efficacy, so you don't have to give IV unless they're intolerant of PO. And then if they don't respond to the steroids, that's when you can get plasma exchange involved for them. And for people that don't respond to steroids, the plasma exchange, I apologize, this is where I got the 70% number. It actually induces remission in 70% of those that are steroid unresponsive. So that pearl that I gave you about the stem cell transplant, erase that one as far as inducing remission. The 70% was the plasma exchange. Darn it, this is being recorded, so now you have all my mistakes for eternity. All right, so now we're going to talk about prognosis and symptomatic care, and I just have maybe about 5 or 6 more minutes, and then we'll take your questions. This is the expanded disability status scale. It goes from 1 to 10 in 0.5 increments, and basically it's a way of stating to other practitioners where somebody's MS disability has them pegged. And also, this kind of gives you a sense of the progression of MS. So FS, you see this a lot of different places. That actually stands for functional system. And so someone with no disability has a score of 0. Someone who has died as a result of MS has a score of 10. When you get to scores of anywhere between 6.5 to 7, that's when a lot of people will start talking about stopping medication therapy, or at least disease-modifying medication therapy for these patients. Prognosis. risk factors for somebody having increasing disability. If they have their diagnosis made when they're older, if they have the higher disability at the time of diagnosis, so these deficits have already accumulated, if they're male, if they have relapses while they're on disease-modifying therapy, these are all risk factors for increasing disability. The good news, though, is that all those medications that I showed you previously are effective in helping to prevent the accumulation of disability in patients with MS. And as far as life expectancy goes, there's a really nice study that was done in Australia just a couple years back, that they showed that the mean life expectancy starting from age 35 for those people that have MS is close to 43 years. So that's less than the general Australian population, but certainly better than what it used to be before we had these effective agents. And then if you look at quality adjusted life years, there is a decrease compared to the general population, but still quite a bit of life afterwards. And at least in their healthcare system, the total lifetime costs associated with MS were somewhere just around $1 million. I bet it probably costs a whole lot more in our system compared to theirs. So symptomatic management, this is something I think a lot of us feel far more comfortable doing. So there's a lot of symptoms that could pop up in the person with MS. Spasticity is a huge one. Those muscles, they just aren't working the way that they need them to, and they can get contractures as well. And then fatigue, bowel and bladder symptoms, difficulty having meaningful sex, cognitive impairments, you can read them all right here. And so the way that you would treat these is fairly similar to the way that you would treat them for anybody else. The only exception I can think about is that there is an FDA-approved medication for those patients with MS that have difficulties with ambulation. I don't recall what the name of it is off the top of my head, but I can certainly look that up and send it out to you later on. And so our last case, the last couple of minutes before I open it up to your questions, we'll talk about symptomatic care. So Deshaun is a 63-year-old patient with MS who's recently been impaneled to you. He is wheelchair bound. He's no longer on disease-modifying therapy. But he is telling you that he is having progressive limitation in his range of motion due to muscle spasms and pain. So think for yourself what your treatment would be for somebody with those symptoms for just a moment. Things that you can do, physical therapy certainly is one of the hallmarks for these patients with these symptoms, encouraging them to be as physically active as they can in addition to that. And then any of the number of medications or procedures that you would use for somebody with spasms, you could use things like baclofen or tizanidine. For people where it's a little bit worse, you could think about benzodiazepines. And then you can even think about implantable baclofen pumps like you would for some of your patients who have other diseases that are associated with muscle spasms and difficulty in coordinating their movements. On a later visit to you, he reports difficulty with bowel and bladder dysfunction. Constipation is pretty common in these folks, and so the way you treat it is just as you would with anybody else, whether that's starting with Miralax, which is, or rather, pegylated, whatever, the generic name. So that's a go-to. But any of a host of other medications that you would use for constipation, watching their fluid intake, their dietary choices as well. And then for a bladder, a lot of times you'll see like essentially an overactive bladder, a detrusor instability. So same medications that you would use for your patients that have those. And don't forget that also there's physiotherapy, physical therapy that you can do for pelvic floor strengthening and all the rest. And then on one of his last visits to you, he describes intractable neuropathic pain, which is also very common in patients that have MS, and the treatment is exactly the same. If you're thinking about anticonvulsant medications, mood stabilizing medications, then you're thinking along the right ways for the treatment of pain in this population. And of course, not forgetting our mental health colleagues, because they can offer them quite a bit as well. All right. Questions so far? So pausing for a moment there. And then while you're thinking of your questions, I'm going to go to that last slide that I have for you. So this is what we talked about. We talked about the diagnosis of MS. We went through a couple cases there. We talked about the evaluation of MS. We kind of lingered on those individual patient cases as well as the McDonald criteria. And then we spent a lot of time talking about the treatment because I like trying to say those really, really long names. You're looking at the slide, you're wondering who everybody else is. On the left-hand side, that's Annette Funicello. We talked about her earlier. In the middle is Montel Williams, giving the lie to the thought that all people with MS are white women from temperate latitudes. And then on the extreme right side, you see Selma Blair. You may remember her from Legally Blonde, was one of the big movies that she was in. Also has MS as well. So I'll stop talking. I have about 10 minutes before I need to jump back into my retirement classes, so I'm happy to take any questions that you have. And I'm going to stop presenting so we can see each other. Okay.
Thank you for that great presentation. There is no questions in the chat, so if anybody has any questions, please unmute and ask your questions. And I also just put in a link in the chat for evaluations, so please complete evaluations.
I'm going to rate myself very, very high. I'm joking.
Aaron, I just want to say thanks. It's sort of a bit of a complex topic, and you always break things down super well to make it easier to understand and give us confidence in our ability to treat difficult illnesses. Thanks.
Well, thank you very much. We've had multiple people with multiple sclerosis on the inpatient ward, so it's always nice to just have a sense of what's happening behind the black curtain that our specialists live behind. And so it's not something where any of us are going to feel expert on. I certainly don't feel expert on it, but just being able to talk a little bit more intelligently with my patients is rewarding, at least for me in this particular area. There's plenty of areas where I talk unintelligently with my patients. So please tell me how your specialist has trained you so I can understand more about this condition. So.
Sir, this is Brian. Can you hear me?
I can hear you.
Okay. One of the things that I find very frustrating in this space is when people have maybe had an incidental MRI and they will have these kind of gray white matter differences that a radiologist says can be associated with that demyelinating disease, but never had an event suggestive of one of the syndromes or the other kind of really significant hallmarks of multiple sclerosis. But you know, whenever you tell that to the patient, they immediately hear, "Oh, I have multiple sclerosis." I'm just curious if there's any recommendations you came across for dealing with that kind of incidentaloma in this, like, kind of cannot rule out demyelinating disease.
Great question. I think a couple of times when I've seen those type of incidental MRIs, we're really fortunate. We have over at Fort Hood a neurologist that really enjoys working with our family medicine service, or at the very least seems to say that to our face, but I think he honestly does. Dr. Cates is pretty awesome. And so he'll actually take a look at those MRIs for us and he'll say, yeah, I'm not really worried about it. Or he'll say, yeah, this person needs to be followed up. I think if there's enough concern that they need to be followed up, and this is me not talking from knowing the clinical practice guidelines, so take it with a grain of salt, but I think what they would say, and I can look this up to make sure, is that you would follow that person, maybe another MRI in a year, to see if there's been any changes to their previous MRI. If there's not, then you're certainly not nearly as worried. If you're seeing additional lesions popping up, then you're maybe a little bit more worried that they have MS or possibly some other type of syndrome associated with it. You certainly would do a lot of history on that patient to get any history of anything that sounded sort of MSE or any neurologic syndrome with them. But I think that's how they would handle it. But again, I'm not speaking from deep intimate knowledge of the guideline. I have to look that particular question up. All right, folks. Well, I'll leave it there. So thank you all for inviting me back to Bethesda for the day. I really appreciate it. Look forward to keeping in touch with all of you. Thank you so much.
Thank you, Dr. Saguil and everyone. Our next grand rounds is going to be on 8th September, and we're going to do that in person. And we're also going to try to live stream, if not record and share it with you guys. So look out for an email coming from me from that. We have guest speakers coming from Georgetown, so we're looking forward to that presentation. So thank you, everyone, and have a good rest of your day.
Oh.